Welcome to the conference session titled Understanding Low Risk MDS. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation from the Q&A icon and the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing, hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming question. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Today's specialist is Suresh Balasubramanian. Dr. Balasubramanian completed his medical training in India. His interest in treating malignant hematology patients started in his advanced training in Singapore in the Department of Hematology and Bone Marrow Transplant. He was intrigued by the advancement of cancer genetics and its application and the development of novel therapeutics. He strongly believes in the concept of being a physician scientist. He completed a year of clinical research fellowship in neuro-oncology at Cleveland Clinic, where he investigated the role of EGFR mutations and ALK rearrangement in lung cancer that had metastasized to the brain. While he enjoyed publishing research in neuro-oncology, he realized his inner calling was for malignant hematology and leukemia research. He completed a translational hematology research fellowship in bone marrow failures and myeloid neoplasms at Dr. Yarek Maciejewski's lab in Cleveland Clinic. He was part of the Cleveland Clinic's MDS AML research group's collaborative effort to perform and analyze comprehensive next-generation sequencing on a large cohort of myeloid neoplasm patients. Soon after that, he completed a hematology oncology fellowship training at Wayne State University. After his fellowship, he is now a clinical scholar with a research and patient focus in malignant hematology. He is working in collaboration with basic scientists at Wayne State University as part of the translational hematology program. With quite a few unanswered problems in the field of clinical hematopoiesis, MDS, leukemia research, his ultimate goal is to grow a physician scientist applying the novel results of sequencing studies and ultimately translate them into advanced patient care. With that said, it is my extreme pleasure to welcome Dr. Balasubramanian.
Thank you, Lee. That was a nice and sweet introduction. I hope you guys can hear me.
Yes, wonderful. Thank you.
Okay, yeah. Let me go ahead and share my screen. Well, I'm one of malignant hematologists at Wayne State University, and I have a research interest in myeloid neoplasms and bone marrow failures currently. And I'm here to talk about the low-risk myelodysplastic syndrome from disease biology to treatment. So when I started preparing for this talk, I thought I should probably restrict myself to like very basic information for patients and their family. But then I realized like the audience may be diverse, like some of them may be like well deep into their treatment, or some of them can be like very early in the start of the disease. So I'd rather invest to put all the slides that I think will be more informative and how these the treatment options evolved over time and what are upcoming as well. So I'll go ahead like directly into my presentation, and please feel free to shoot your questions in, and Lei will probably moderate them towards the end of the session, and I will try to answer them. If not, I'll leave my email address, and we can definitely have a conversation later on. So I do not have any conflict of interest with respect to this presentation. I might have some off-label use that may be discussed, and sorry for the typo there. So I'd like to put in perspective with respect to patient, and this is not a HIPAA violation, and I just used a Photoshop to edit my face. How will I look when I'm probably 74? I think it still looks a little bit young for 74, but that's okay. So, this is one of my patients, but I changed all the information for this presentation. So essentially, there is no HIPAA violation here. So a 74-year-old man, a typical MDS patient, like how would they present is like gradual worsening fatigue for several months. What they could do earlier, a year or a couple of years prior to the presentation, they couldn't do it anymore. Like if they were running a marathon, they couldn't run. If they were doing things like, regularly that they used to enjoy, they couldn't do it. So the most important past medical history was just the diabetes, but nothing else. And the patient was a smoker for almost 25 years, but quit 10 years ago. Maybe it had some impact to his disease presentation. And he was otherwise healthy looking gentleman with a good performance status, and he wasn't short of breath at rest, and no petechiae or any kind of like bruises under his skin that was obvious on examination. So the next best thing that we always look into it is what are his lab parameters, like just basic labs like complete blood count. When I checked it, it was a total white count of 5,400 and a normal differential count. Like we do look into what are the components of your total white count, which is essentially neutrophils, like eosinophils, different kinds of white blood cells. And there was a normal differential, like normal distribution of different types of white cells. And what we call it as blasts are immature cells of like, which is the hallmark of like MDS transforming to a more serious cancer like acute myeloid leukemia. So there wasn't essentially anything circulating blasts in the peripheral blood. When I checked, his hemoglobin was only 7.4. 7.4 is definitely low, and a normal man would have it around like above 14, and women have slightly lesser threshold, but still like it's like way up above 13. And reticulocytes are baby red cells, which gives you a perspective of how good your bone marrow in terms of producing new red blood cells. When you are anemic in a normal bone marrow, you expect a lot of reticulocytes, but in this case, it was low. So there is a concern for a bone marrow failure. MCV is nothing but a mean corpuscular volume. It means that how big your red blood cells are. A normal sized red blood cell should be between 87 to 95 or 100. Anything above then is macrocytic, meaning like the cells are bigger. When the cells are bigger, it's considered kind of immature. So that's a concerning lab parameter. And there were no issues with platelet count, like it was 156,000. So that's probably the reason he didn't have any bruise or petechiae or any of those things. As part of the workup, like erythropoietin is very essential, and erythropoietin is considered like a hormone which is secreted by your kidneys, which helps in boosting up your red blood cell count. And body's natural mechanism is to pump up your erythropoietin when your hemoglobin is low. But this patient had lower than expected erythropoietin for his level of hemoglobin. So this erythropoietin is probably, like many of you who had been worked up, your hematologists have done this erythropoietin level. It's essentially to know whether like one of your treatment options that I'm going to discuss will be effective for you or not. So as part of the workup, absolutely, like it's not the best, most pleasant procedure, but in the best hands, I don't think it's, it's that difficult, but, we need to get a bone marrow aspirate and biopsy. So when I looked into the biopsy for this patient, it was hypercellular for age. It means that there were like more number of cells than expected for age. Like as we age, the number of cells in the marrow should also decrease, but it was more than expected. So I talked about blasts earlier. Blasts are immature cells, and though there weren't anything circulating in the peripheral blood, in the bone marrow, we saw around 3% blasts, which is slightly high, but not super high. And when we look into the bone marrow, we look into the morphology of every cell out there. And bone marrow is nothing but like the production house. So we want to see what is there inside the bone marrow and how do they look. So it did show dyserythropoiesis, meaning like the red cells were kind of abnormal looking and they were big. And there was something called, ringed sideroblasts, like which is kind of an iron accumulation, like in certain parts of your cell, and which looks like a ring inside the cell. And we estimated that to be 22%. I'll come to that, like why it is important. So no dysplastic changes in the megakaryocytic lineage. What it means is that like there was nothing in the platelets that were abnormal. And we did get the cytogenetics, which I will talk in the next slide, like what are these cytogenetics and what is like next generation sequencing. In a normal man, like 46XY means like it's the chromosomes are good, like it's like all 46, all these chromosomes are intact, and an X and Y has no problems. The next generation sequencing is like looking at the ultra level within the DNA for any mutations, and it found like something called SF3B1 mutation with a variant allelic frequency of 22%. Like probably for your better understanding, you can assume like 22% of like cells analyzed, which is not exactly the same, but just for understanding purposes, 22% is somewhat like having this mutation SF3B1. So with this background, the patient was diagnosed with myelodsyplastic syndrome with single lineage dysplasia, and also had the presence of ringed sideroblasts. So MDS with SLD/RS is the diagnosis. So just to give a brief introduction, like, I know we will, or most of your hematologists talks about bone marrow repeatedly, but I want to educate you all about like why we want to look into the bone marrow. As we all know, bone marrow is the production house for all your cells that are circulating. I would say like most of it. So it is present in the middle of like certain bones, especially in the long bones and towards the end of the long bones. And when we grow from an infant to an adulthood, like there are some parts which gets like attrition, and like only certain parts of your marrow becomes like continuously active. So it is made of blood forming cells, fat cells, and as well as supporting tissue. The most common area where we access the bone marrow is usually the hip bone. And in some individuals, like if we need an aspirate but not a biopsy, we can even access a sternum for it. These are two common areas. So what does these bone marrow contain? Like, the parent cell is called the stem cell, and this parent cell can remain quiescent and then like divide and like differentiate into any lineage based on what the requirement is in a normal cell physiology. So if you look at it, like there are two major divisions, like myeloid stem cells and the lymphoid progenitor cells. The myeloid stem cells gives rise to eosinophils, basophils, monocytes, megakaryocytes, which ends up being platelets, and neutrophils and red blood cells. And the lymphoid progenitors has like, it can differentiate to T cells, B cells, and NK cells. So our, like we are talking about myelodysplastic syndrome. So it's more towards the left end of the picture. And what are the lineages that can be affected because of a problem within the, either within the stem cell or even above or even below. So if you talk about myelodysplastic syndrome, we need a definition. What is myelodysplastic syndrome? These are fancy definitions like that is evolved over time. If I want to read the first one, it comprises of a heterogeneous group of malignant hematopoietic stem cell disorder is characterized by dysplastic and ineffective blood cell production and a variable risk of transformation to acute leukemia. If I further want to define that, it's a group of hematological malignancies characterized by clonal hematopoiesis, one or more cytopenias, and an abnormal cell maturation. I can keep talking more fancier definitions, but in short, MDS is a cancer. So let's get that clear. So I think it's important to characterize the beast because I think it is very much a prerequisite to tame it. So studying the epidemiology of myelodysplastic syndromes has taught us a lot of things that we use it to progress the research in myelodysplastic syndrome. We all know MDS is not a homogeneous disease. Like every patient with MDS is different. And it is a heterogeneous group. So one pathogenesis or one treatment or one follow-up approach may not be applicable to any other patient with the same disease though. So it has been hampered, the epidemiological assessment has been hampered by evolving diagnostic criteria. If you look at it, like, there were several diagnostic criteria that evolved in the past decade that kind of did not even define MDS as a cancer until 2001, when we agreed that it should be considered as a cancer. Around 10,000 people in the United States are diagnosed with MDS each year. This is just a rough ballpark from SEER website. And it is definitely a disease of older age. I don't know where to draw the cutoff for older age, but it is not a common entity for patients who are younger than 50 years. And of course, exceptions do happen. Like if you have any germline or like genetic familial predisposition, you could get like MDS prior to age 50. So the incidence is around like 4 cases per 100,000 population. If you look at acute myeloid leukemia, which is, I consider MDS towards the left end of the spectrum, whereas acute myeloid leukemia is towards the right end of the spectrum. It follows, closely in terms of incidence, but definitely like MDS is more common. Like not all MDS will be transforming to acute myeloid leukemia, especially we are talking about low risk MDS, which has a longer latency to become acute myeloid leukemia. So as you see from this graph, like it's probably not common when you're around 50s, but definitely picks up a good acceleration after 65. And it is more common as we age between 75 and 80. And acute myeloid leukemia probably follows the same pattern as well. So overall, like if you look at it, males are slightly privileged to get myelodysplastic syndrome for various reasons, which probably are more corroborative, which we still do not know entirely why males have a slightly higher predisposition compared to females. And when you look at survival probability, like MDS is often not considered serious, like, but if you look, if you put every MDS together, your best survival for 5 years is only 31%. Of course, there are myelodysplastic syndromes that I'm going to talk about, which is low risk. Your median survival is like 4 to 5 years easily. But when you look at more aggressive forms, like therapy-related myelodysplastic syndromes, or patients who have received chemotherapy or radiation in the past and you develop myelodysplastic syndrome, their survival is much, much shorter. And there are a group which is kind of more towards the acute myeloid leukemia spectrum, where it is called as refractory anemia with excess blasts, meaning like there are more blasts in your bone marrow, which would put you at a higher risk, and their average survival is median survival is around 12 months or so. So MDS is definitely heterogeneous, and the survival within the same group can be very wide, and it all depends on how their disease presentation is, and also what are the other genetic features that we are trying to learn that would accelerate the disease much faster in one patient over the other. So putting in perspective, this is a SEER data from 2017 with respect to other cancers. Of course, pancreatic cancer would be the worst killer disease, but if you look at myelodysplastic syndrome, it's probably, it's still worse in terms of survival probability compared to your colon cancer or breast or prostate cancer or a kidney cancer. So something that is still serious enough to be addressed, and that's probably the reason there is a lot of research currently going on to improve these outcomes. So people do ask me when I meet them for the first time, like, what did they do to get that myelodysplastic syndrome? The biggest risk factor is age. So I will talk about like why age could be a risk factor in a couple of slides from now. As we know, like, age is the biggest risk factor for most cancers as we grow, and there is a chance that we acquire mutations, and there is a chance these mutations can lead to cancer. Of course, with environmental exposures like smoking or like being obese, being male, of course, is not something like environmental, but it's an inherent risk factor by itself for myelodysplastic syndrome. And prior receipt of radiotherapy or chemotherapy is definitely a risk factor for myelodysplastic syndrome. So besides these, some patients can remain idiopathic, like meaning like I don't even have a reason why they got myelodysplastic syndrome. But my belief is that these patients, and we kind of like getting to know more about like germline predisposition to myelodysplastic syndromes. I think maybe in 5 to 10 years or like more research, we will probably be able to define these idiopathic cases, why they got myelodysplastic syndrome, because there is a lot of evolving information about certain genes that probably we are born with. They can just get mutated, or like they're mutated to be present with, and then they can later add on like further mutations and present at a later age as myelodysplastic syndrome. So going forward, I talked about evolving classification. So if you look at it, WHO's classification from 2008 and 16, this has probably helped us a little bit about redefining the abbreviations that we were using in 2008. I would like to concentrate more on the 2016 classification system. It's essentially like, I'm going to go from the top to bottom. Like, if you look at the green shaded boxes on 2016, these are probably the low risk MDS that we're going to talk about. That is myelodysplastic syndrome with single lineage dysplasia. What it means is either you have a problem with your red blood cells or like neutrophils or your platelets. And MDS with ring sideroblasts, and as you recall, like our patient that I portrayed in the beginning had ring sideroblasts. So having ring sideroblasts probably puts you at a lower risk stage. And of course, there are other things that can influence your risk stratification. And MDS with isolated del5Q has not changed from the prior era of 2008 classification. And it's probably considered like a good sign because you have a targeted treatment for that. When you have involvement of more than one lineage, 2 or 3 lineages, meaning like red blood cells along with your white blood cells, along with your platelets having problems in myelodysplastic syndrome, that is considered a little bit more serious than your single lineage dysplasia. And when you have excess blast, I talked about what is blast, right? The blasts are immature cells that's not supposed to be circulating or be present in bone marrow in excess. So when you have excess blasts, up to 20%, like which is called as EB1 and EB2, above 5% to 10% is EB1, and 10 to 19% is EB2, meaning like excess blast. We're just quantifying like how much blast in the bone marrow. And this is kind of more red alert that this patient is probably progressing towards the right end of the spectrum that I talked earlier, which is the acute myeloid leukemia, a serious form of myeloid cancer. So these are patients who are in general high-risk patients to be classified as. And there is an entity which is unclassifiable, and probably we are currently exploring like genetic features to classify them in a better way that some patients fall into this category can be better defined in future maybe. So this is quite a common question that I get, like, what is the stage of my cancer? Because most of these questions probably stem from their relatives, patients' relatives, or friends having like breast cancer or lung cancer. They're always staged differently, like stage 1 to stage 4. We don't stage MDS unlike solid cancers like breast or lung. So, but if we have to use something closer, I would say risk stratification system. We have been using risk stratification system in the past called IPSS. By far, this is probably the foundation, and many of other risk stratification systems that evolved from this probably added like a couple more points here and there to further stratify them to very high, very good risk to good risk. But majority, this covers most of your parameters for risk stratification. If you look at it, like if your overall score based on like whatever parameters you score for, if it is low, that is 0, and then like your median survival is close to 5.7 years. Whereas if you have a score of about or 2.5 equal to about 2.5, your high risk MDS and your median survival is like less than a year. So, but this is an age-old classification. Of course, we are learning more and more about genetic features in myelodysplastic syndrome. Of course, we have not yet incorporated that into your stratification system because there is like a lot of data that can be more controversial for and against the influence of these mutations. I'm going to talk about what are the genes that may be implicated in a second or so. So why do we have to risk stratify them? Because this is going to influence our treatment decision in terms of risk stratification. So asymptomatic, I will go over the current treatment algorithm in low risk myelodysplastic syndrome. But this is just a general overview that if you have a low risk patient who's asymptomatic and their counts not needing any problems, any transfusion support, we can just observe them until they become symptomatic or progress. So, and then low risk, of course, has wide variety of treatment options. I'm going to go over each one of them in detail and the studies that probably support their use in low risk myelodysplastic syndrome. High risk myelodysplastic syndrome is something that I'm not going to touch, and I have my colleague who's going to go over in detail in an hour or so. And high risk is probably in spectrum with low risk, and we know towards the right end of the spectrum is always acute myeloid leukemia. So I talked about risk stratification systems that evolved over time, and IPSS is something pretty much standard but there are other risk stratification systems like IPSS revised, WPSS, and like MD Anderson has its own risk stratification system. So when you look across all these risk stratification systems, it can be it may look confusing, but it is probably not, because the bottom line is how bad is one's cytopenia, or the second question is like, is it like one cell line affected or more than one cell line affected? Does the patient need transfusion support? And what is the blast percentage in the bone marrow? When I look at any patient's bone marrow report and their clinical presentation, these are my 4 questions that helps me determine where they belong to, whether they belong to the left end of the spectrum or in between, or towards the right end of the spectrum, which is a high-risk myelodysplastic syndrome, or towards the extreme right side, they're marching towards the acute myeloid leukemia. So there has been like further refinement, as I talked about, like the time-dependent changes in mortality and what is the transformation risk in myelodysplastic syndrome. The revised IPS is better define this cutoff. Like if you remember and recall, like I said, like more than 2.5 in IPSs is considered high risk. Here they had a cutoff of 3.5, which further defined them, like further identified like certain subgroups with better mortality. So I want to go over this because this is going to be our future of myelodysplastic syndrome, which is even currently like being incorporated, but there will be a time where incorporating genetic mutations to score everyone's response to a particular drug versus risk stratification for prognosis will be widely applicable. To that note, I want to make everyone understand like what are these that we are talking about. When we take an individual cell, like we are all like aware that like individual cells contain chromosomes. We have these chromosomes are the genetic materials, and this genetic material contains like if you further magnify that, like you will find chromatin, which are smaller forms of it. And if you further magnify it, the genetic representation is your double standard DNA material. And if you further magnify it, like these are essentially like different base pairs that pair with each other to come in different combinations to produce certain proteins in the body. So if you have problems with the whole structure as such, the chromosomes, we kind of look in your bone marrow report. We do something called karyotyping or cytogenetics. This is nothing but looking into your overall structure of your chromosomes, whether you've lost one of your chromosomes, 7 or 5, or did you lose like the short arm of your chromosome? Did you lose your long arm of your chromosome? So this is what we are essentially looking at, like the largest part of your genetic material. Is there any problem with that? Because MDS, I'm going to go over in a couple of slides from now. So MDS can have changes in a bigger picture, like it can have chromosomal abnormalities. Some patients may not have chromosomal abnormalities, and that's when we do like next generation sequencing. It's essentially to find mutations which are just probably like one base pair difference that's not supposed to be the case in normal persons. So we can identify genetic information with next generation sequencing at that ultra magnified level. So some patients who has normal chromosomes can have mutations that could be pretty seriously driving their disease. So this is what essentially will be the future of like how we gonna risk stratify and also estimate the prognosis of patients. But currently we do not have a system that puts all their mutational profiling in their classification system yet. I mean like all the genes that we know are implicated in myeloid diseases. So when we look at the stem cells, like, I told you about the parent cells, like why do we even think about mutation and why age being a risk factor? If you look at it, like in early life, you're probably estimated to have like 10,000 to 20,000, 200,000 like hematopoietic stem cells in your bone marrow. But it is a natural selection that you will have, like there is always a error in replication, and we always have a proofreading mechanism to correct it. So if you estimate there are 10 mutations per year, and 2 can be in the coding, meaning like it could affect the protein changes, and 200 can be in the non-coding, meaning like it may not really do anything. But body has the ability to correct these mutations and proofread them and get back to normal. But if you look at it, like there are almost 1 million coding mutations by the age of 70. So as we age, there are accumulation of mutations. I'm not saying all these mutations are clinically relevant and important. Like there are several patients who may not have any problems acquiring these mutations and be normal and living a normal life. But in certain, these mutations over a period of time can affect an important function of a protein and can lead to myelodysplastic syndrome. And this is called clonal hematopoiesis of indeterminate potential in patients who do not have any symptoms, but this has some of these mutations has the potential to become myelodysplastic syndrome when we diagnose them. So, bottom line is age is a biggest risk factor for acquiring mutations, and age is the biggest risk factor for developing myelodysplastic syndrome also. So this is a little bit complicated picture, but what I'm trying to put in this is, if you have a patient with MDS and I'm sequencing them and I find 2 mutations, these 2 mutations can be one after the other, like that one happened, the light blue happened first and the dark blue happened second, or both happened at the same time, or he could have had like something he was born with, and the second mutation just happened later part of the time, and it could be just 2 codominant events. The reason to tell you this, describe the slide is just not to, not 2 mutations together. If it presents, it can have different implications based on how it evolved, like A followed by B, or A and B together, or B followed by A. It all means that 2 mutations are present when we bulk sequence them, but the order of mutations may have a role. It's still not completely proven yet, but this is how heterogeneous a disease can be, and a disease trajectory can change based on like how you acquire your mutations. All right, so going into more clinical route, like we said, like, okay, age can be a risk factor. There are other risk factors we talked about, like MDS is a de novo disease, meaning like it just happened, and then when we diagnosed a patient who clinically presents with these symptoms, we assume that they are de novo disease. But when you look at it, I also talked about MDS could evolve with mutations that are supposedly benign, but some mutations can be functionally important, and then they can lead to MDS. So one school of thought is that MDS probably has a pre-disease phase, but we are not able to still catch them at the pre-disease phase. But whether catching them at the pre-disease phase has an impact on the overall survival or improving their outcomes is still a million-dollar question yet to be answered. Maybe that will be the future of diagnosing them pre-disease and able to prevent the disease progression to myelodysplastic syndrome. But that's something like more research. So I talked about MDS mutations, meaning like, what are the number of mutations that we have seen like across like different gene sequence. Like I talked about like looking at the ultra magnified level of DNA, like what problems and what base pair substitutions has happened. So there are different genes implicated. But when we look at it, like most of them are either intermediate risk or low risk, meaning like we do not yet completely know or certainly know like how much impact it makes on the prognosis for myelodysplastic syndrome. One gene which is widely accepted to be favorable prognosticator is SF3B1. And patients with SF3B1 mutation morphologically will have ringed sideroblasts, which I talked about, which will look like a ring of iron around the cell, inside like a structure in the cell. So this is probably one confident gene that we can call it as like better prognosticator, but rest of the genes are either intermediate risk, or they have like confounding results based on the studies you're looking at, or some of them are low risk at this point. So going into the treatment part, I'm going to mix up the treatment part along with how we can follow up later on. Once you started on treatment, essentially like follow-up care post-treatment along with this. So patient with low risk myelodysplastic syndrome based on IPSS classification, that is like scores of less than or equal to 1, or your modern risk classification, which is a revised, which is score of less than or equal to 3.5. This slide was adapted from Dr. Sekeres from his HASH education program. I find this to be very useful. I talked about earlier, there are patients who present to the clinic with mild symptoms or no symptoms, and routine blood work by the primary care physician had numbers which were not supposed to be normal, but at the same time do not require any kind of transfusion support. These are patients who would be the low risk towards the left end of the spectrum. And based on their blood counts, you can probably monitor them every 1 to 6 months, but essentially observe them. There is no need for any treatment. And we have had patients who never required treatment and be followed on their counts maybe for 7, 8 years without any problems at all. But there are some patients who would probably be progressing to a level that they need like transfusion support and other treatment options that I'm going to talk about. Or in this central part of the figure, like we will talk about isolated cytopenias, meaning like either they have anemia, thrombocytopenia, or neutropenia. How do we manage them, and what are the treatment options available? What if they have multiple cytopenias at presentation? So, or they develop multiple cytopenias after they were treated for a single cytopenia. So I will go over this slide again for each of the treatment options that I'm going to discuss in the next few slides. So how do we choose therapy to treat lower risk myelodysplastic syndrome? It's always important that a low risk doesn't need aggressive treatment option. So lower intensity agents are generally well tolerated as well, and so we try to take it easy in terms of most low risk patients. Until they need treatment, we don't essentially treat them. And we try to ameliorate the significant cytopenia and try to lessen the symptoms and improve the quality of life. And bottom line that I try to set up with my patients, at this point, the goal is not to achieve long-term disease control or prolonged survival in patients with low risk MDS. So what influences these treatment options is like, is it an isolated cytopenia versus like multilineage cytopenias? So essentially your treatment option will differ. And if outpatient setting is usually preferred, and toxicity profiles have to be discussed with the patient based on their comorbid illness. And of course, cost is a big factor in determining like the right treatment option. Of course, it's not going to essentially influence if the treatment is absolutely needed, and availability of the treatment option and convenience of administration as well. And above all, when we discuss these options with the patient, patient preference, it's pretty important and oversees everything that I talked about earlier. So how do we manage anemia and myelodysplastic syndrome? If you recall my patient that I presented earlier, we check something called erythropoietin. When patients present with myelodysplastic syndrome, that's one of the important laboratory parameter that we check is erythropoietin. Is erythropoietin adequate enough for that hemoglobin or not adequate enough? The response to external erythropoietin support, erythroid stimulating agents that we call it as ESAs, it entirely depends on your level of erythropoietin. If your erythropoietin is super low, then there is a good chance you will respond to erythropoietic stimulating agents. This is a meta-analysis that looked into different studies that used EPO support, like it's essentially a growth factor for red blood cells. It's very wide based on the study you're looking at, but if I have to quote what is the average response for this external support, erythropoietin support, I would probably call between 15 to 40%. I know it's pretty wide. If you have to ask me, maybe like 1/3 of the patients would respond to EPO support. And there are parameters to risk stratify or like stratify them based on like whether they would really benefit from standardized EPO or not. We use something called Hellstrom-Lindbergh score, and we have a more revised HLS score which divides them to very good and good, which is essentially like looking at how low their EPO levels are. If the EPO levels are less than 2, they get a higher score. If they're more than 500, they're not likely going to respond to erythropoietin at all. So we never have to even think about using erythropoietin support. So this is a rough score this is a good score that helps us to determine whether how good a patient is going to respond to erythropoietin support. As we see, if a score of 4 or 3, then the response probability is very good and good. And of course, like score of -1 or +1 is going to be a gray zone call. Like some may respond and some may not. And of course, like a negative score is unlikely to respond to erythropoietin therapy and definitely not recommended to use for treatment. This patient with MDS, as you recall, he was treated with erythropoietin stimulating agent since the levels were 60. As you recall, if it was less than 100, there is a very good chance he's going to respond. So he enjoyed a decent response for 16 months, not requiring transfusion, and hemoglobin decreased from 7.4 to 10.6. And after that, he dropped back to 6.8, and the biopsy showed. And again, like every time there is a drop in counts or failure of your therapy, your hematologist is going to recommend doing a bone marrow biopsy just to know where we are standing, whether we are in the left end of the spectrum or towards the middle, or are we marching towards the acute myeloid leukemia side. The bone marrow biopsy confirmed the same diagnosis. However, the next generation sequencing this time identified a new mutation, EZH2. There are drugs in the pipeline, research pipeline, but nothing currently approved for it yet. And cytogenetics, the larger picture of the chromosome, found that like the 5q part of the chromosome is deleted. So this is prognostically important because there is a targeted treatment available for this. I know there are patients who do not have del5q and still you can use the targeted treatment, but patients with del5q respond definitely better to it. So if you look at this algorithm that I showed earlier, in the center column where the patients with hemoglobin of less than 10, you start them on erythropoiesis stimulating agent. And if they lose response at some point or no response, or if they have an evolution of del5q, meaning like you're losing one arm of the chromosome 5, then there is a drug called lenalidomide, which is pretty good in terms of del5q myelodysplastic syndrome. And of course, at any time, I would like to do next generation sequencing to look at mutational profile every time like I change treatment or a patient loses response. Essentially to look for available clinical trials, because enrolling them into clinical trials is very, very important for myelodysplastic syndrome, as we are yet to look into the curative treatment option at some point in time. So del5Q MDS, there was a study which was a randomized phase 3 study that looked into treating patients with lenalidomide versus placebo in patients who required transfusions for lower or intermediate 1 risk myelodysplastic syndrome with del5Q. If you look at the response rate, there are different numbers that they're quoting, but on an average, I would say 40% of patients have shown response in this with this treatment regimen. So you may ask, what is the median duration of this response? I've seen patients with median duration lasting more than 2 to 3 years, in fact. And even in the study, the median duration of transfusion independence is close to 2.2 years. So you may ask this question, will del5Q be the only inclusion criteria to get lenalidomide? Not really. Even non-del5Q patients can be treated with lenalidomide, but of course, your treatment response may not be that great. But though this study was was showing around 25% of patients responded, and of course, these are transfusion independence estimated at 8 weeks, but if you follow them for longer, the response may be not that lucrative as we saw with del5Q, but still it's a treatment option that your hematologist would try. So in patients with myelodysplastic syndrome and ring sideroblasts, we saw if they fail erythropoietin stimulating agent, or they wouldn't likely respond to ESA because their erythropoietin level at baseline was very high. Then there is a newer treatment option which was recently approved, which is called as luspatercept, which is a TGF beta, which affects the TGF beta pathway, which helps in the red blood cell maturation, essentially. And this is a treatment option which is recently approved, and which has shown pretty good results for transfusion independence. If you look at it about, I would say a meaningful response is probably about 12 weeks at least, and transfusion independent at 12 weeks was around 33%, which is in the luspatercept arm, versus placebo had a noise of around 12%. This is an approved treatment option at this point. And the median duration of transfusion independence has lasted for some patients to 30 weeks. So you can see can increase the mileage with the addition of this drug to the treatment paradigm. So essentially, if they fail lenalidomide or erythropoietin stimulating agent, luspatercept is definitely an option in this, as I just alluded to. So coming back to our patient, he was treated with ESA, he was treated with lenalidomide, and then he had some mileage with luspatercept. But then now the counts have dropped back to 7 of hemoglobin, total white of 1600 with a neutrophil count, which is 800 now, platelets are 30,000. And he has a new mutation, which is ASXL1, and cytogenetics still revealed L5Q. Definitely, as I alluded to earlier, whenever you have a progression or decrease in counts, you want to make sure what is happening in the bone marrow. And he did get a bone marrow biopsy. Now it's again 2% blast and dysplasias in all 3 cell lines, whereas when he started off, he had only 1 cell line issue. So going back to this treatment algorithm, when you have multiple cytopenias, one could either do anti-thymocyte globulin, which is immunosuppressive agent, or a hypomethylating agent. So when you look at low platelets alone, just an off-label use that one can use is romiplastin, which is essentially a platelet growth factor. And romiplastin has shown some positive results, but at the same time, the concern was whether we are accelerating the disease from myelodysplastic syndrome to AML. So this is something very much cautioned among how and when to use this romiplastin or L-Trombobag, which is a platelet stimulating agent. So patients with higher blast percentage count should be cautiously monitored, and I would probably avoid using it. But with low risk MDS and a low blast percentage who needs a treatment to boost their platelets, and this is not a bad option to try. And how to tackle multilineage dysplasias, and we just mentioned about hypomethylating agent. FDA has approved like azacitidine and a similar drug, decitabine, for myelodysplastic syndrome. It's essentially like, why do we choose is based on the differences that we find in this table. Azacitidine is subcutaneous as well as IV, so it's whereas decitabine is IV only. And the treatment option, the treatment duration is 7 days for AZA, whereas for decitabine, it's 5 days. So slightly less time in the infusion center for AZA. And if you do a subcutaneous route, it's much easier. Whereas like decitabine will make you stay for an hour at the infusion center. And but it's kind of a give and take, and based on the institutional's preference and patient's preference, like one may choose over the other. But again, there is no big difference between azacitidine and decitabine, although some studies, smaller studies, has shown like decitabine is slightly better over AZA, but there are no larger studies which has shown robust results that one is better over the other. So can we use, like some patients have this problem of not able to tolerate the full dose that has been approved, that is 7 days of AZA versus like 5 days of decitabine. Like this was a study that was done like with shorter duration of decitabine and azacitidine, like only for 3 days. And the median follow-up of around 20 months, and overall response rates were close to like on an average of 50% to 60%. Which is slightly above than what you really expect with the 7-day course. But of course, that we cannot do a cross-trial comparison. But a lower dose of decitabine or azacitidine duration could possibly be used in patients who are not able to tolerate like the full dose of the same drugs. So in patients who require the treatment option of azacitidine, there is a more recent study which looked into the oral form of the drug, which is CC486, in a phase 3 randomized study that was just recently published in low-risk myelodysplastic syndrome. There was around like 1/3 of the patients responding to the drug on a 21-day regimen out of 28-day cycles. They achieved RBC transfusion independence, and the median durations lasted around like 11 to 12 months. So in patients who do not prefer to go to the infusion center, this is probably an alternative option that could be tried. So I talked about multilineage, that is like different cytopenias. If a patient presents with something called hypoproliferative MDS or hypoplastic MDS, then there is a role for immunosuppressive therapy called ATG, and it can be used in combination with steroids and cyclosporin. And a study that looked into it's a retrospective analysis that looked into the usage of this immunosuppressive therapy in hypoplastic MDS, and they found a response rate close to 45 to 50%, which is pretty remarkable. But not all patients with multilineage dysplasia or cytopenias are going to respond. There are different aspects that can influence your response for this drug. But the major point is you have to be really hypocellular marrow, that is less than 20%. They are found to be responding better. And of course, there are other parameters like HLA-DR16, and having a PNH clone. So I'm not going into the details of it, but having a hypocellular marrow, ATG could be a treatment option. Coming back to our patient, he was treated with erythropoietin stimulating agent, and then he was on lenalidomide, then on luspatercept, and even tried on azacitidine. So he had enjoyed some good response with that, but the hemoglobin dropped back to 6, total white count of 1,200, platelets have crashed to 15,000, and the bone marrow biopsy showed hypercellular marrow with 16% blasts. Now he is in the MDS with multilineage dysplasia and excess blasts too. The NGS showed the same mutation that were identified earlier, but there are new mutations like TP53 and DNMT3A. And cytogenetics was complex, meaning like there were multiple chromosomal abnormalities on the larger magnification picture as well. So now this patient is marching towards the high-risk myelodysplastic syndrome, or give it more time, maybe an acute myeloid leukemia even. So he was referred to bone marrow transplant, which is the only curative option currently in the treatment modality for high-risk myelodysplastic syndrome, which my colleague will touch base pretty soon. Or, so he failed all the treatment and referred to transplant. So this is essentially the only curative option, as I discussed. So more than these treatment options, what is more important for myelodysplastic syndrome, be it low risk or high risk, the supportive care is very important. So we try to keep a hemoglobin above 7. And of course, if they have a heart condition, that would demand a slightly higher hemoglobin threshold with transfusion support, and platelets of about 10,000 or 20,000 if they are bleeding. Generally, antibiotics or antiviral prophylaxis are given while on treatment, but no other proven role otherwise in MDS, not routine prophylaxis is usually done. And of course, a case-by-case treatment selection or antibiotic prophylaxis is probably needed. But in general, like, we do not prophylax patients with antibiotics and antivirals. So hematopoietic growth factors, we talked about erythropoietin, but in general, we do not use romiplastin, that is the thrombopoietin analog, which boosts your platelets, or like granulocyte stimulating factors, which boost your neutrophils, because there is a theoretical concern that you can progress your MDS with high blast, or like MDS with slightly more blast, to blast off and become like more aggressive form of the disease, like acute myeloid leukemia. And of course, my patients in this era, especially with COVID, they talk about vaccination, and vaccination is highly recommended. May just avoid the live vaccines, but otherwise, like, age appropriate vaccines are very important because they are immunocompromised, and there is a chance that you could get serious infections, and it's better that vaccination is done at appropriate times. How do we monitor the disease? Like, we do blood parameter monitoring. We talked about CBCD, reticulocyte counts, and everything. And we do get bone marrow biopsies as by the clinical need, meaning like if the disease progresses, or like if there is a treatment failure, or something based on that clinical spectrum where the patient belongs to, a bone marrow biopsy is always needed. And in my practice, I always get a next generation sequencing every time I do a bone marrow biopsy, or every time I have a concern that there is disease evolution, especially to look for any novel therapeutics and clinical trials where we could target any mutations that are currently in pipeline, like for which there are drugs available. So when we transfuse the patient, like, iron overload status is very important, because more and more transfusion you get, there is a chance like you will end up like overloading your iron, which has indirect implications if the patient ends up living longer with a low-risk myelodysplastic syndrome. So need for chelation treatment, that is to get off the excess iron in your body, should be discussed. With this, I'm coming to the end of this talk, and where else you can get more information? There is like a bunch of resources except Google. I would highly recommend going to any of these websites. And AAMDS is, last but not the least, has been a tremendous resource for patients as well as even for physicians, helping them network with the right people so that they get the right information and make the disease better managed. So MDS low risk is definitely a marathon. It's a long run. There are a lot of treatment options, many of them in clinical trials. Talking to your physician, exploring clinical trials, and making the best use of current technologies to monitor your disease is the best way to go. And with that, I'm going to end this talk, and please feel free to reach out to me. I'm more than reachable by my email, and I'll be happy to answer any questions now or in future if you may have. Thank you.
Thank you so much for the wonderful presentation. We do have a few questions. Our first question is, what is the usual progression of MDS from high risk to low risk?
May I just rephrase the question? Is there a progression from high risk to low risk, you said?
What is the usual progression of MDS from low risk to high risk?
Oh, okay, great. So as I said, like it's pretty much like it's all time dependent question for any patient. It's just not like there is no common number to predict. Like it all depends on multiple parameters that we're going to look at. Say, for example, if you have a patient is 78 who is considered to be low risk, not requiring any transfusion support, or their bone marrow biopsy is like 1% blast, like there is no mutation that is like concerning, like TP53, those kind of things. These patients, when you follow them up, like if they die by another cause of a disease, like say a heart attack at 86 or 87, essentially you kind of never had the chance to even look into their progression to the higher risk MDS. Whereas if you look at like other patients, if they are younger, say in the age of 65, and if they have enough time to be followed up for a longer run, but they have high risk features like multiple cytogenetic abnormalities, they may require a little bit of transfusion, but not to the level that they are considered high risk, or they have some blast percentage that is slightly increasing over time, then these patients probably can progress within a year or two to high risk myelodysplastic syndrome. So this question is probably not, it's a great question. We are trying to learn as we go along, and that's why, like, if we get more information on the impact of these mutations and chromosomal abnormalities, like, and of course a clinical presentation as such, we can probably predict for each individual patient like what might be the risk of their progression to high risk myelodysplastic syndrome. I hope I answered the question.
Yes, thank you so much. Our next question is there a link between Agent Orange and MDS?
Oh, that's a great question. You know what, this is probably my I think the 15th time or 16th time like I'm getting this question. There is the other hematological malignancies. I think it was linked to CLL. What I would say is anything environmental, if it can cause one form of a cancer but not proven in the other, doesn't mean that it doesn't exist. But at the same time, like, don't quote me on this, because most of these are speculative and like temporal relationship, like just happened at that time and happening this time. You're trying to marry each other. It is possible, but if you ask me if there is any research published that has shown that, probably not. So anything in excess has the propensity to do genetic damages. It can be so many things. It can be smoking, it can be like the pesticides that we use, but these are one of the many. So it's hard to pinpoint that, like, that with just one exposure, because there is a lot of other confounding factors to it. All patients who are all of them who are exposed to Agent Orange, did they get MDS? Then it makes sense. Or did they have other risk factors for it? Like, did they have a gene that was already weak, like from a germline predisposition? Were they a smoker? Like, were they obese? So there are other players in it. It might have contributed, but of course it cannot be just by itself. Yeah.
Our next question comes from a patient who is 75, low risk, in good health, low blast, but has failed all the therapies you mentioned, has a choice of having a transfusion every 2 weeks or moving forward with a stem cell transplant. How does a patient make this type of decision?
It is definitely a tough choice. Like I think it probably is better answered with the hematologist who is following, because there is a lot of intricacies in this. What's the patient's preference? Like, either they want to be in a transfusion support, taking care of their iron, excess iron, and be on the transfusion program forever, versus like taking the risk if they are in good shape to go to transplant, like if they have a good donor availability. There are several other factors with respect to transplant selection. Certain centers are comfortable transplanting patients even in their late 70s, and certain centers may not. So it also depends on the availability of transplant and also the comfortable, factors that might influence the transplant. So that's on the other side. The flip side is like, are they willing to take the risk of a transplant? So I think the best thing is to get a transplant consult for sure, and understanding the risks and benefits of transplant, and knowing these two things in detail, and getting themselves better educated about the risk and benefit would probably help them make an informed decision. And of course, exploring clinical trials is also a good option. It's a great option, in fact. Like, if somebody is not keen to go into that intensive route of transplant, which would require like hospitalization, chemotherapies, follow-up, being on immunosuppressants, and of course, there is a risk of death with transplant. One could explore clinical trial options across the country here, and enrolling in a clinical trial would be the best alternative, if not for the two.
Thank you. Do you feel it is necessary for MDS patients to have the booster shot for COVID-19?
This is an excellent question. Actually, like right off this moment, like we are having a trial in our center right now, looking into hematological malignancies, and in fact, like we have enrolled quite a few patients already. The trial looks into checking their antibody titer. I think we have a cutoff about 2 or something. We originally started that in myeloma, and then we have extended that to different myeloid neoplasms as well, or hematological neoplasms. So we are enrolling those patients to get a third booster shot if they don't have adequate antibody response titer based on our trial requirement. So I think we don't have an answer outside the trial, but in the trial there are a few trials that are running to look into the effect of booster shot. And again, like with respect to COVID, nobody knows like what's the adequate antibody titer level that will help you prevent getting reinfection. And of course, like in patients with hematological malignancies, the caveat is they probably may not mount an immune response adequate enough, especially if they're on treatment. So logistically speaking, it's a great option to try be enrolled in a trial where they do the booster dose and be monitored. In my opinion, I think having better antibody titer in your blood is better than having low antibody titers. If booster would help as part of a clinical trial, I think it's not a bad option.
Thank you so much for sharing your time and your expertise with all of us today. If you'd like to watch the session again at a later time, it will be available on the conference platform within the next hour by accessing the session, clicking on replay, or by navigating the on-demand tab in the platform hub. If you have any additional questions, you can send it to us anytime within 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-5600, 2820 extension 2, or submit your question to our Facebook page. Please be sure to visit our exhibit hall today. The next educational MDS session will start in approximately 15 minutes. On behalf of the foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 37 years. This concludes the session.